Welcome to the all viewers and well-wishers of the world. Purpose of my lecture is learn the knowledge from the word, return the knowledge to the word. The motto of my life is learn, earn and return. I have learned a lot, earned a lot, now to return a lot to the word. The topic of today is Pityriasis alba. And commonly it is said to be the white spot seen on the face of the kid and the other people. So actually it is the name of the disease is Pityriasis alba. The condition is named for fine scaly appearance, Pityriasis, and alba, Latin for the white color of the patches that develop. It is a skin condition, a type of dermatitis, or the mini form of the eczema seen in the children and the young adults as dry, fine, scaled, pale patches on the face. The patches are not totally depigmented. It is self-limiting disease and only requires use of the moisturizer cream most of the time. Exact cause is unknown. Here one can see the Pityriasis alba on the face, the white patches one can appreciate, and here again the white patches, these are just here. The patches are round, oval, or have a wavy shaped border, poorly demarcated, and these are multiple hypopigmented macules or patches. Some are smaller than a coffee bean or larger than a golf ball, appears in children who take hot baths frequently or who are exposed to the sun without sunscreen. Pityriasis alba is not contagious. Here again one can see the white patches of the different size on the different part of the face, and these are very prominent, and this can be appreciated on the skin of the face of the children most of the time. Epidemiology, it occurs in children and adolescents of all the races, particularly people with dark skin. The worldwide prevalence is 5% in the children, with boys and girls affected equally. History is it was first described in 1923, having variety of the names. Term Pityriasis alba was coined in 1956. Before it was given the different name. Now, sign and symptoms. The dry scaling appearance during winter due to dry air inside the homes. During summer, due to tanning of the surrounding normal skin, makes the patches of the Pityriasis alba more prominent. Pityriasis patches do not tan, mostly on the face, cheeks, but also on the upper arms, neck, and shoulders or the belly. Lesions are round or oval, raised or flat, from 0.5 to 2 centimeter in size, larger if they occur on the body, so they are up to 4 centimeter in diameter, usually 4 to 5 to over 20 in numbers are seen. Here one can see on the arms and on the face, that is very usual, but also on the arms, that is very commonly seen. Now, sign and symptom. Individual lesions develop in 3 stages and sometimes are itchy. The first stage is raised and red papular scaling. Erythematous redness is often mild and not noticed by the parents. Number 2, a type of lesions are raised and the pale papular scaling, hypochromic, and number 3 are smooth flat pale patches. Smooth hypochromic patches are seen. The duration of the Pityriasis alba varies from 1 month to 10 years, and lesions are usually bilateral. Here one can see the very prominent lesion on the back of the chest and also on the different part of the body and on the legs and the back of the chest. Now, legs and trunks are rarely involved. Sun exposure may increase contrast with the normal skin because surrounding skin becomes tan and pityriasis patches do not tan, so wearing sunscreen make patches less noticeable in the summer months. Light patches are also more noticeable in the people with the darker skin. Atrophic sebaceous glands were noted in 50% cases of pityriasis alba. Now, the cause related to the atopic dermatitis or eczema that causes a skin rash by excessive use of the corticosteroid creams to treat the episodes of the eczema. Hypopigmentation is due to the reduced activity of the melanocytes with fewer and smaller melanosomes, so hypopigmentation is seen. Degenerative changes in the melanocytes and reduced keratinocytes melanosomes is also one of the reasons. Dry skin and atopic dermatitis may coexist, not infectious agent have been identified, so there is no infective agent responsible for that. Condition is more common in males than in female. Perhaps they're the more exposure to the outside and in the sun. Role of the ultraviolet radiation, bathing or not bathing, low serum copper and malassezia yeast is not clear, but it is said to be having some association with that. But xerosis seen in the atopic dermatitis is important. Leading theories about origin involve atopy and post-inflammatory changes, hypopigmentation secondary to the pityriaxitrin, a substance produced by the malassezia yeast that acts as a natural sunscreen, iron deficiency anemia seen in the 16.5% cases, excessive and unprotected sun exposure, poor hygienic habits, and environmental influences are also responsible, such as temperature, humidity, and altitude. They have some role in its cause. Now, certain associated factors which have been seen with this pityriasis alba, that is family history of asthma and hay fever, eczema in the area of the atopic dermatitis, history of rash at site of the hyperpigmentation, skin irritation produced may heal with post-inflammatory hyperpigmentation, history of the prior therapy, potent topical steroids may produce hyperpigmentation, history of the irritant or allergic contact dermatitis from various topical creams, lotions or the medications. When these area recovers, an area of the post-inflammatory hyperpigmentation may occur. Seasonal variation have been seen also. Now, variants of the pityriasis alba. There are two main variants of this disease: pigmenting pityriasis and extensive pityriasis alba. First, the pigmenting pityriasis, typical lesion on the face, has a central zone of bluish hyperpigmentation surrounded by a hypopigmented, slightly scaly halo of the variable width. Lesions are confined to the face and associated with the dermatophyte infection, especially tinea capitis, may be related to the lichenoid melanodermatitis. The other variant is extensive pityriasis alba. There is widespread, as the name is, there is widespread and symmetrical involvement of the skin, absence of the preceding inflammatory phase, a primary acquired hypopigmentation in female aged 18 to 25 years of the mixed ethnic origin are the susceptible cases, a higher female to male ratio seen, and histologically the absence of the spongiosis lesions are less erythematous, less scaly, and more persistent, asymptomatic mostly on the trunk, less on the face. They have not reported atopy or the familial occurrence in extensive Pityriasis alba. Increasing in number and coalescing over whole trunk into larger patches surrounded by smaller, well-defined macules. Ultrastructural studies suggest a reduced number of the active melanocytes and a decrease in the number and the size of the melanosomes is the reason in older children and adults, the early erythematous lesions of the Pityriasis alba are mistaken for the psoriasis, but distribution, lack of the psoriatic scales, and the sparing of the scalp, elbows, and the knees, which is seen in the Pityriasis. So this excludes this diagnosis of